Thank you so much for having me. Today, I will present a project we are conducting in Pakistan to build the formal financial and health numeracy skills of illiterate and innumerate women in northern Pakistan. The project is still in progress, but I will share some of the preliminary work which we have conducted to date and the few of the work which we have completed until now. The University of Alberta acknowledges that we are located on Treaty 6 territory and respect the histories, languages, and culture of First Nation, Métis, Inuit, and all First People of Canada, whose presence continues to enrich our vibrant community. In today's presentation, I will provide an overview of financial literacy and numeracy skills among women in Pakistani context. I will present the baseline survey findings, which we have completed, and I will share oral information management tools which we are developing as a part of this project to build the financial and health numeracy of illiterate women in Pakistan. Pakistan is also my home country. There is increasing recognition that economically empowering women is essential for both to realize women's rights and to achieve broader sustainable development goals. Women's economic empowerment is particularly important for women and adolescent girls because their financial decisions are critical for their own and their family finances, nutrition, health, and education. Financial literacy is a combination of awareness, knowledge, skills, attitude, and behavior, which are necessary to make a sound financial decision and ultimately achieve individuals' well-being. Financially literate individuals do better at budgeting, saving money, control spending, debt handling, particularly in financial markets, planning for retirement, and accumulating wealth. A widely neglected element of financial capability is financial numeracy, which is defined as the financial skills required to carry out financial transactions with understanding in real time without the help from a third person. Research supports strong positive link between women's empowerment in the formal economy and foundational health outcomes for women and their families, including beneficial effects on nutrition, family planning, maternal mortality, and child mortality. In addition, evidence also indicates that increasing the share of monetary household income controlled by women may produce other benefits, including greater investment in children's education, greater control by women over their reproductive health, delayed early marriages, decreased teenage pregnancies, and reduction in gender-based violence. However, evidence suggests that women and adolescent girls have lower formal financial literacy than men and also lower confidence to integrate into formal economic, monetary, and financial systems. Lack of formal numeracy skills also impacts health numeracy. Health numeracy is the degree to which individuals have the capacity to access, process, interpret, or communicate and act on numerical quantitative health information, which are needed to make effective health decisions. Women with low numeracy skills cannot read and understand basic medical directions containing numerical information such as instructions on medication bottles or the date and time of medical appointments, and also are unable to calculate medical fees. Research shows that individuals with low numeracy compared with those who have high numeracy are less likely to understand health risk or to comply with medication regime, underuse screening tests, have greater difficulty managing chronic conditions, and report worse subjective health. Thus, formal numeracy skills are important for women's economic and health empowerment. Many women's economic empowerment programs in low and middle income countries do not build the financial numeracy skills which are necessary to successfully handle and leverage cash transfer, loan, credit, and saving. And without financial and health numeracy, women cannot advance towards more sophisticated financial literacy skills, such as household budgeting, making effective use of bank account, or comparison shopping for the loans or other financial services and healthcare decision making. Pakistan is a home to approximately 220 million people. According to 2020 World Bank report, the literacy rate in Pakistan is 58%, and the literacy is lower among females compared to males. and it's more lower among the women and girls who are living in rural areas. Pakistan also ranked poorly on the Gender Inequality Index. Over the past 15 years, attempts have been made by both government and civil society organizations to improve the status of women. Although both sectors' efforts are constrained by insufficient fiscal resources, furthermore, limited access to formal schooling, socio-cultural barriers, lack of awareness of gender-based discrimination, and limited access to financial literacy have limited rural women's socio-economic development. Government of Pakistan and some NGOs have further concentrated on providing better and more effective social welfare schemes for the benefit of rural women. Specifically, rural support programs are playing an important role in women's economic empowerment in Pakistan. There are numerous successful NGOs run rural support programs across Pakistan. The Aga Khan Rural Support Program, AKRSP, which began in 1982, is the oldest and is major non-profit organization established by Aga Khan Foundation, working in Gilgit-Baltistan in Chitral, which is one of the 5th province of Pakistan and formerly known as Northern Pakistan or Northern areas. Aga Khan Rural Support Program overall goal is to improve the socio-economic condition of the people of Gilgit-Baltistan and Chitral through a variety of intervention strategies, which includes institutional development, women development, natural resource management, participatory infrastructure development and enterprise, and rural financial enterprise development. Our project is located in Gilgit-Baltistan and Chitral. Gilgit-Baltistan and Chitral is situated at the geostrategically sensitive border area bounded by China, India, and Afghanistan. It is comprised of 10 administrative districts and is home to approximately 1.8 million people. As with the rest of Pakistan, Gilgit-Baltistan and Chitral present a complex diversity in how women and men experience inequality. Barriers to equality and empowerment are generally far greater for women than for men. A labor market assessment shows that only 17% of the women participate in paid labor, whereas some 50% of the women are completely illiterate and homebound. For women and adolescent girls' economic empowerment in Gilgit-Baltistan and Chitral, Aga Khan Rural Support Program has implemented numerous programs and strategies such as self-employment project for women, women-only market, and women agro-entrepreneurs. To promote women's economic empowerment, Aga Khan Rural Support Program also initiated a community-based saving group program. The main purpose of community-based saving group program is to support and facilitate access to maternal and child health services by women of reproductive age. It is intended to overcome the serious challenges many of the women face in that area in accessing the healthcare in time due to lack of public transport, high fares, distant health facilities, travel time, and uncertain availability of the trained healthcare providers from formal health sectors in many of the rural and remote areas of Gilgit-Baltistan and Chitral. With the majority of the population living in abject household poverty, earning around $2 per day per household, most women are unable to afford healthcare from a skilled birth attendant. Community-based saving groups are a simple yet cost-effective and sustainable means of providing basic financial services to low-income, marginalized rural women, so they can invest in income-generating activities to build saving, to access maternal and child health services whenever it is needed. These are also called as village savings and loan associations in some part of low and middle income countries. Despite Aga Khan Rural Support Program's success today to empower women through community-based saving groups, important barriers to progress remain. A prerequisite for women economic and health empowerment and gender equality and women's ability to participate in formal financial and health numeracy and the ability to count, calculate, read, and write large numbers and participate in healthcare decision-making for their families. Not only are these skills deficit as a chronic challenge during the AKRSP community-based saving group program, but they also continue to act as a constraint on women's and girls' ability to consolidate their gains after graduation from the community-based saving group program and to maintain engagement with formal financial and health system. Closing this skill gap in the view of AKRSP is more important, which will then trigger a more sustained momentum out of poverty. It enabled the women to continue up the economic ladder and improve maternal and child health outcomes and promote gender equality. So in this project, we are introducing oral information management solution, which is usually called as OIM solution, to improve the financial and health numeracy skills of illiterate and innumerate oral women in community-based saving groups in Gilgit-Baltistan and Chitral. In this project, we are applying My Oral Village, oral information management solution within the context of AKRSP community-based saving groups programs, to integrate financial and health numeracy training to promote both formal financial and health numeracy among illiterate and innumerate oral women in Gilgit-Baltistan and Chitral. MOVE, basically we are using the MOVE designs, which mainly design interface for financial services that oral adults who cannot read and write, they can safely and confidently use these interfaces or these designs. To make these designs, MOVE utilize a process and set of tools which are called oral information management. People who cannot read and write, they need oralized financial records. So these tools include, but are not limited to, the use of pictures, icons, and stories. In this project, we are developing OIM tools, which include oralized community-based saving group passbook, their loan forms. We are also going to introduce an orally table, which is a cash calculator, and I will talk more about it later in the presentation, and an oralized health calendar. Our core hypothesis is that illiterate or innumerate women who will use OIM formal numeracy solutions will become increasingly comfortable with numbers and improve their basic numeracy skills. The integration of health calendar will improve maternal and child healthcare utilization. We are conducting this project in Kharmang district of Gilgit-Baltistan region. Kharmang is one of the remotest valleys in Gilgit-Baltistan. Before the development of the tool, we have conducted a baseline survey to evaluate, to understand the women's demography in our project area and also evaluate the women's financial and health literacy skills. A cross-sectional survey was conducted among a random sample of 162 women from community-based saving groups residing in Kharmang district of Gilgit-Baltistan. The study used the financial numeracy survey tool to test participants' financial and health numeracy skills. The survey interviews were conducted in Balti local language. The survey included community-based saving group women with a mean age of 34 years. Majority of the women are married and have little to no experience in business. Women in Kharmang mainly undertake farming and household work. For education, there is an overwhelming practice that still exists that men and women join madrasa, religious seminary, when they come to age. In these seminaries, religious scholars teach religious scriptures and the Holy Quran. Nowadays, modern education is concurrently provided at almost all places in the district. Of the 162 respondents participated in the survey, 90 participants reported that they attended a madrasa, with 47 participants completed reading the Quran. 46% of the total sample of the population are illiterate or reported they have not attended the school at all. And 11.7% have some post-graduation education. The reading test was administered to a random sample of members in each community-based saving group. The 3 probes were used to gauge if participants can read text and numbers within a simple sentence, as you can see in this box over here. In addition to words, the respondents were asked to read one 4-digit number and one 2-digit number included in the sentence. From the graph, you can see that most of the participants have the ability to read a small number, 67%, whereas 54% were able to read the written words in the test sentence, while only 36% of the participants were able to read the large numbers. All community-based saving groups comprise of approximately 20 members, so on average, 1/3 of the participants were unable to read words and faced great difficulties. Since all community-based saving groups record keeping involves the ability to read and write long numbers, this means that many individuals face great difficulties in carrying out these responsibilities. The study also showed a strong correlation between school attendance and the ability to demonstrate their skills. In spite of this, it is striking that even among those who are totally unschooled, over a third could read a 2-digit number. This indicates a strong motivation to learn and suggests that even this is a very remote area, opportunities to learn these skills is available. There's a poor or weak correlation between age and ability to read small prints. Counting money is also important as the women in the community-based saving group encounter instances involving record keeping, counting, and saving as part of their daily routines. To assess the level of understanding of women community-based saving group members related to counting money, a simple test was designed where cash mounting 830 Pakistani rupees in different denominations were provided to them, and they were asked to count the cash. 66% of the participants have been able to correctly count the banknotes and coins. The rest of the participants failed to do so or declined to answer. The counting strategy is also very important measure of recognition of the sum given to them for counting. The strategy adopted by women is present in this graph over here. The women were also asked to recognize the amount they just counted on a sheet with 5 numbers. One of the number was 830, the same cash sum given to them. 48% of the respondents correctly identified the number. Women's numeracy is also very important for them to make important decisions and make daily routine dealings. The women were also aware of its importance, and 88% of the women said that the numeracy is important for them. Community-based saving groups operation also involve frequent calculation as the member buys shares, like they make deposits and receive and repay funds. The ability to perform several mental calculations is presented in this bar graph over here, with the strongest skill on the left and the weakest on the right. There's a considerable overlap between these skills and those required as a user of health services, which also begin with the ability to read numbers and draw the understanding of concepts such as fraction and ratios. The strength of the skill on the left reflect that the women in the village use traditional means to make fractions and volume calculations. 83% of the women correctly answered the fraction questions and 67% were able to correctly answer the volume calculation. Though women are mainly involved in agriculture and household activities, they are also required from time to time to work outside their fields as they go to buy their groceries or other items for the daily use. Handling of somewhat large sum was assessed in a question and check if they were able to correctly answer the questions in a hypothetical arrangements. 57% of the women correctly answered these questions, while 33% incorrectly answered and remaining 10% declined to try. The CBSGs also require women to handle percentages as well. The women were assessed if they were able to make share calculations or not involving percentages. Only 17% of the women participants were able to correctly answer these questions. The rest either declined to answer or answer incorrectly. The women were also asked whether they make decisions on their own or have major say in their household decision making. The answers have been filtered, and these responses you can see in this graph here. The responses only of married women, because widowed and unmarried women responses are mostly irrelevant in this context. Household decision making is the highest in the category of 25 to 36 years old, followed by 37 to 48 years old, then those 49 years and older. The education of the respondents and their household decision-making also been compared. There is no change in their role in decision-making with their household with education level. This lack of correlation between educational attainment and decision-making likely reflects the traditional roles of the women and the patriarchal tradition of the which is very common in Pakistan. However, there is also exists the possibility that since women typically are not the main income earner, their say in household decision-making is low. Health numeracy of the women participants was also evaluated. Dates are a very important indicator of women's ability to track and record their health calendar. In villages, there are certain traditional ways to remember the age of individuals. To remember the age, they use loskors. It's a Balti word for tracking the age. So one loskor is equals to 12 years. However, this practice is now being replaced with modern Georgian calendar year is used as a reference. Only 30 out of 162 respondents, like 19%, were able to correctly state the three components of their date of birth. The respondents were provided a vaccination card, and it was used to gauge their understanding related to their children's vaccination. Date of last vaccination was correctly answered by 24% of the women, while date of future vaccination was correctly answered by 22%, with the rest of the respondents unable or incorrectly answer the question. Pregnant women were also asked to answer their pregnancy term if they were in a certain period of their pregnancy. 60% of the women who were pregnant were able to correctly identify or tell with what pregnancy term they are in. Youngest childbirth date was answered by 29.6% of the respondent. On the other hand, 91 eligible respondent, 35% of the respondent answered the weight of their youngest child correctly, and child height in centimeter was only answered by 4.39% of the eligible respondent. Decision-making about the child health is another important aspect which the participants were asked about. Only 10% of the participants said that they fully make health decisions related to their child health. However, 50% of the participants, of the women, said that they have a major say in healthcare decision. Based on the baseline data, we have developed these OIM tools. So the saving passbooks, which right now is being used in community-based saving pass groups, are now being oralized. So on the left-hand side, you will see the old passbook, and the right-hand side is the new one. Sorry. So on the left-hand side, you will see the old passbook, and right-hand side is the new one, which is now been oralized and developed based on the OIM solutions. For the contextual adaptation, we conducted focus group discussions with the community-based saving groups to ensure the images we are including in the passbook are understandable by the women in the community-based saving groups and are contextually based. So here is another example, on the left-hand side is the old passbook, which is being used in the community-based saving groups. And on the right-hand side is a new one, which we have developed based on the OIM solutions with images and icons. So this is the OIM-based passbook, which is now being developed. And soon we will be used by the women in the community-based saving groups. Along with oralized passbook, we have also introduced Orally Table, which was designed by the MOVE and runs offline on Android devices. Orally Table translates images of currency into numbers and vice versa, which enable poorly schooled women to verify the financial transactions they participate in and record or check financial records. Participants will gradually understand place value by repeatedly generating cash amounts on Orally Table to keep their savings and their financial records. Over time, they will gain fluency with longer written numeracy string as well as confidence in writing the numbers using this device. They will also learn to recognize the primary arithmetic operators which appears as they perform the calculations, such as adding loan or interest amount. So, this is basically like kind of that it will convert the numbers into the rupees, And based on that, the women will learn how to do the calculation and make their financial or keep their financial records. Here is some pictures where women are practicing or learning about the orally table. After 3 months of the training or the introduction of these OIM tools and orally table by the women in the community-based saving groups, we will conduct inline survey, also some of the focus group sessions, and we'll also conduct some key informant interviews to evaluate the usability and effectiveness on these tools and in building the financial and health numeracy skills. So we believe that orally table and OIM records will safely and sustainably build basic formal numeracy and record keeping capabilities. Our OIM, formal numeracy and health numeracy interventions for illiterate and innumerate women will play an important role in supporting women economic empowerment and achieving gender equality by promoting access, control over financial resources, and financial and health decision-making into the hands of the beneficiaries. Our goal is to ensure that formal numeracy and health numeracy skills are used not just during the project, but permanently acquired and used throughout the lifetime of project participants, permanently improving their confidence in interacting with formal financial, formal healthcare, and formal numbers. The last, I would like to acknowledge Funds for Innovation who have funded this project, My Oral Village, who is helping in developing OIM tools for the community-based saving groups, and AKRSP, who is providing their full support to access the community-based saving groups and the participants in the community-based saving groups. Thank you so much, and I'm open for the questions.